There it is. It's going now.
Good morning. My name is Samantha Fury. I'm a student at Columbus State University, and I'm going to do a PowerPoint on pressure ulcers, evidence-based practice pressure project proposal for pressure ulcers. Pressure ulcers are a serious concern in the United States. Thousands die in hospitals as a result of pressure ulcers, and billions are spent in treatment of pressure ulcers. Can the training of nurses, the use of negative pressure wound treatment, and patient repositioning every 2 hours affect patient outcomes? Evidence-based practice articles and methods will be reviewed. Based on the results, a treatment plan will be designed to help staff prevent, identify, and treat pressure ulcers. Change should start today. However, it is estimated that it will take a year before pressure ulcer methods and procedures are in place to effectively improve patient outcomes. Prevention, identification, and treatment of pressure ulcers, and hospital-acquired pressure ulcers. Hospital-acquired pressure ulcer is the injury to the epidermis and dermis caused by pressure, shear, or moisture while in the hospital. This is considered a sentinel event and should never have occurred. Pre-existing ulcers are only pre-existing if identified on the initial assessment. So if you get a patient in and day 2, you just go, oh, they had a pressure ulcer. Now it's the hospital problem. It's no longer the pre-existing. Centers for Medicaid and Medicare services refuses to pay for unnecessary and preventable cost. And a pressure ulcer is a preventable cost. Institute for Clinical Systems Improvement reports that extend the length of hospitalization, sepsis, and mortality. Estimated 60,000 U.S. hospital patients die each year of complications from HAPU. Cost of managing a single full thickness pressure ulcer is costed as high as $70,000. Total cost for treatment of pressure ulcer in the United States is estimated to be $11 billion per year. I will identify evidence-based methods to prevent, identify, and treat pressure ulcers. As a patient advocate, I will develop a project proposal to be adopted specifically for a med-surg floor or for a home health environment. This proposal can be modified to be used in ICU, OR, ER, or long-term care facilities. Prevention of pressure ulcer will improve patient outcomes. Prevention, identification, treatment of HAPU and pressure ulcers. Patients will experience improved quality of life. Patients will spend less time in hospitals, and patients will have fewer complications, including less deaths. Patients in the hospitals will experience decreased medical expenses. Patients at risk for pressure ulcers, existing pressure ulcers, stage 3 or greater pressure ulcers in the past, hypoperfusion states such as sepsis, dehydration, or heart failure, disease processes, peripheral vascular disease or diabetes, smoking or restraint use, spinal cord injury, immobility, incontinence, impaired sensation, or individuals receiving epidural or spinal pain medications. Palliative care, OR, ER, and heart services for extended periods of time. Pre-existing ulcers, previous ones that patients have come in with from home due to non-skilled caregivers, PAD, and venous insufficiency. These all contribute to pre-existing pressure ulcers and or chronic ones. Location of pressure ulcers: sacrum, coccyx, heels, elbows, shoulders, head, anywhere there's a bony prominence or a point of unrelieved pressure. Goal 14 of National Patient Safety Goals: prevent HAPUs, assess risk factors. Pressure ulcers are in all healthcare settings. and they should be prevented and stopped at stage 1. A written plan for risk identification and prevention. Conduct a thorough initial assessment, reassessment at intervals. Use a risk assessment tool such as a grading scale, and educate staff and identify and prevent ulcers. Joint Commission 2017. Root causes. Was the pressure ulcer present before admission? And if it was, what stage is the pressure ulcer? What diagnosis did the patient have? Did they have any comorbidities? What is their past history? And or do they have a risk that can be identified to help prevent them from the red spot escalating? Prevention measures taken. Is the staff educated and trained on the care of pressure ulcers? Adequate plan of treatment, is that in place? Has the doctor instituted that? Communication and collaboration issues. Are all people taking care of the patients aware of the issues and communicating with each other to provide the best care for the patient? And are evidence-based practices being used? And technology to reduce risk, such as beds and pillows, beds with the wave mattresses and that sort of thing. Are those being used? The PICO question: how does the use of trained pressure ulcer nurses on the med-surg floor and the use of negative pressure wound treatment and patient repositioning every 2 hours compare with non-skilled identification, prevention, and treatment of pressure ulcers? The first pressure ulcer I ever treated was when I was a CNA years and years ago. And I went to this patient home, and they told me to get this lady up out of bed and give her a bath. And they didn't tell me that she had anything wrong with her. So I went in to get her up and take her in the shower, and I said, oh, she can't stand very well. And I walked into the room, and there was this smell that permeated the whole room. And there was no dressing on the wounds. And the patient was laying flat on her back and not positioned on either side. And she had a big sacral ulcer. And after that day, I went back and told the home health agency that I was working for that I didn't have training for this, and I was not going to do this. Because I had no training, and nobody provided me any training.
I don't blame you.
So that was my first introduction to a pressure ulcer, and it wasn't pleasant.
Right.
And neither are they for the patients. I reviewed 3 articles, and Article 1 had a level 2 applied to the randomized clinical trial. And it reduced costs by quit using the negative pressure wound treatments. And that saved money, but in the long run, it did not improve patients' outcomes. Article 2 showed a improvement by the use of using NWPTs, and it was a very cost-effective intervention. Article 3 showed evidence that not raising the bed higher than 30 degrees so that they weren't putting pressure on their coccyx and sacrum, and turning Q2 hours was the most effective treatment. Access to patients' Braden scale, pressure ulcer risk. Assess a patient's sensory deficit. Can they feel? Are the patient continent? Is there moisture? Are they going to be laying in moisture? Is the patient active or sedentary or bedfast? Mobility status, can they move themselves? Even if they are in the bed, can they move? These are all things that need to be assessed. Nutritional status, does the patient consume enough food to maintain their weight? Or are they losing weight? If they're continuing to lose weight, their pressure ulcer isn't going to improve. If they aren't given enough protein, their pressure ulcer isn't going to improve. They have to have lots of protein in order to affect this. And friction and shear, can the patient support their own weight independently? You have to pull them into bed. And if you have to pull them into bed, then you have risk of tearing the skin. Okay, evidence-based recommendations for pressure ulcers. Provide training for personnel. The Braden scale is an excellent tool to use. A scale of less than 12 places a client at risk. The patient should, from the physician down to the nursing at 8, if they're at a risk of pressure ulcers, they should all be notified of this so that proper treatment and interventions can occur. A wound ostomy and continence nurse, called a WOC nurse, should be hired. They have over 200 hours of taking care of wounds. And most facilities, well, I can't say most. Small facilities cannot have the money to spend on this sort of nurse, just because they're a very well-paid nurse. And so if a small facility does not have the money to pay for this, they should get a nurse that's interested in learning about wounds to go and shadow other nurses so that they can learn and bring back the facility. The wound pressure devices shouldn't be used unless you've been trained in it, because it can actually cause major damage to the skin tissues and surrounding area if they're applied improperly. And National Patient Safety Goals provide us with tools to identify risk, prevent ulcers, manage existing conditions, and improve patient outcomes. Q2 turning a risk should begin immediately. Head of bed should be elevated no greater than 30 degrees. If the patients can tolerate this and it's not contraindicated. If the patient has congestive heart failure, they may have to sit up higher than that because they can't breathe with it lower. Pillows should be floated, and there should be no skin-to-skin contact. Pillows should be put between knees, and pillows should be put between arms and torso. Skin barriers should be applied to prevent further damage to skin on the areas that are next to moisture. Physicians should include all this in the plan of care. Patients and families should be educated on the need for repositioning so they can help manage their own care. And due to the small size of rural hospitals, not only must evidence-based practices be submitted to the med-surg supervisor or administration owners, but it has to be cost-effective. Otherwise, they won't do the changes. CMS rewards for quality care and refuses to pay for unnecessary care. And HAPUs are preventable. Education staff provides better treatment, and economic evidence supporting NPWT and wound treatment includes early discharge and faster healing, fewer admissions, better patient quality of life, and improved cost effectiveness. Repositioning patients and pressure ulcers prevents pressure ulcers and decreases cost. Effectiveness of evaluation, 0 HAPUs, and patients with pre-existing ulcers will spend less time in the hospital due to complications from pressure ulcers. Nurses will feel more confident when providing care to patients with pressure ulcers, and patients will have improved quality of life due to decreased length of stay in facilities. And in the small hospital that I prepared this PowerPoint for, implementation, 1 month, provide evidence to the med-surg floor, supervisor, administration, owners. 1 month for intervention of pressure ulcers based on the physician's orders. 3 months of education for a nurse trained in wound care and in service for the rest of the staff on pressure ulcers. 2 months to formulate a care plan and put in new policies in place. And 2 to 4 months continuing ed and staff checkoffs. This would be with a trained nurse following around staff to make sure that proper assessments are done and that they know how to identify and prevent the ulcers. Then staff charting would be compared the first 3 months, keep track of new, existing, and previous pressure ulcers. And then after that, check weekly progress and reassess interventions and implement changes as needed. And at the 1 year mark, should have established change, and it should be standard operating procedure for pressure ulcers. Expected outcomes, patient quality of life as a result of evidence-based practice will be improved. And summary, staff training and education is paramount for proper treatment and prevention, and use of negative wound pressure treatment would improve patients' outcome, and repositioning Q2 hours. Evidence shows that these will improve patient outcomes and will be cost effective. Any questions?
How did they develop again? Like
The pressure ulcers develop from pressure. And if a patient is laying in a position for greater than 2 hours, then the skin starts to get a red spot on it. And then that is considered a stage 1 when it's just red. And if they continue to apply pressure to the area, then it actually causes the skin to necrose and it starts breaking down. And so you can have an intact skin on the outside, but the inside can be permanently bruised and lose the feeling. And that's why you get black
which I have seen
tissues.
I've dealt with a client who has worn, but he's bedbound, and so he doesn't really care for people to move him.
Okay.
And so it's like there, and the skin is starting to rupture,
Uh-huh.
but it's not to where it leads too bad. He just sits there. He just sits on it.
Okay. All right. Well, a lot of times they lose sense to it depending on how deep it is. They can't feel it. And they can actually die from the pressure ulcer. So they need to get off of the pressure ulcer, even if they don't want to. Eventually it's going to rupture and start bleeding. And then is it on the sacrum?
It's
The coccyx.
right on the bone.
Okay,
right on the end of
okay.
it.
All right. Well, then he definitely needs to go side to side, and he doesn't need to be greater than 30 degrees in the bed.
So that's also a challenge, but
Okay.
that's another that's another conversation.
When people die, is it from the sepsis, like when it gets infected?
It sets up infection. It gets in the bone. It can cause osteomyelitis, where it's in the bone, the infection's in the bone, and it can cause them to go septic, and then they can die from the sepsis.
Never heard of people really die, but
I haven't
it just
either.
gets
That
more
kinda
and more
shocked me.
complicated.
Well, one person that's famous that died was Superman. One of the Supermans. He died due to pressure ulcers.
What was he septic? Like, is that what happened?
I don't know the specifics, but I know that he died from complications due to the pressure ulcers.
Wow.
So,
Yeah, there's a woman that I took care of for about a month. She is completely bedbound. She's been for years, but she just has excellent skin care.
well, is
I've
she
never
able to
seen,
move herself?
No, not at all. I mean, she can barely move her arms, and that's
Okay.
it.
All right.
But
Well,
you know,
she's had really good care.
within taking care of her for just a month, I never saw. But we'd turn her over, clean her good, make sure she was dry. Apply
Yes.
lotion. If
Right.
there were any spots, immediately put one of those skin.
The barriers.
Yeah, put a barrier on there. Make sure she was always dry and lotioned, and repositioning her
Okay.
often throughout the day.
Well, you did. Those were what needs to be done for all patients that
Yeah.
are at risk or that can't move.
I think
Themselves.
she's at such high risk that
So-
you have to really, because she
Okay.
can't move at all. So
That sounds like y'all are all doing the correct steps, and it's great that she had no skin breakdown.
yeah.
I mean, we have a few that are bedbound that they don't have any, like, nothing, because they're constantly being repositioned. So
Yes. And they actually recommend that you don't use briefs, but a lot of times they have C. diff, and you can't not use briefs. So that's an issue. Mhm.
it really did. It really did. Like what? They can die? But
Yeah, that's I've
Yeah.
never heard, but I guess not just from the initial, but from the complications
The
as it gets
ongoing.
worse and
And
worse and worse.
comorbidities. I mean, because if they're in the position where they are prone to get a bed sore, an ulcer, then they've got other comorbidities that's contributing to the problem.
Mhm.
And that's when the Braden scale, when it goes down. Because without all those, that's what they assess to determine what the Braden scale is. And with it low, then they're immediately at risk.
It's pretty interesting stuff.
Well, thank y'all very much.
Thank you.